He's very. Yeah, he's just.
Nice day.
Dr. Suggs, our chair, and Dr. Friel.
My wife, say hi to Charlie Friel. Yeah. Thanks for coming. Yeah. It's a great day. The only person. It's a great celebration of Herb and also the reading and all the hard work. You'll see how hard she works. The C-square fall apart and like still be like, nope. Yeah, I'm waiting for the PI to respond. Your point, like, not a lot.
Except at 4:20.
Oh,
36.
I don't know, like, the reviewer. But I mean, we can't all highlight anything like that. An IBIB. You know, on the review, like that roster, there were some data scientists, but the problem is that my first submission is like their
Maybe we'll get started with Tran round. Was on. Good morning. It is my distinct pleasure to be introducing Dr. Christine Tran. Dr. Tran was born in Richmond, Virginia, to parents Peter and Imelda Tran, who are here with us today. She completed her undergraduate studies here at the University of Virginia as an Echo Scholar, graduating with the Bachelor of Arts in Neuroscience with the highest distinction. She commissioned as an ensign in the U.S. Navy through the Health Professions Scholarship Program prior to beginning medical school here at UVA, and is now completing her general surgical training as a triple two. Following graduation, Dr. Tran will be stationed in Portsmouth, Virginia, where she will serve as a lieutenant commander and attending general surgeon for the U.S. Marine Corps 2nd Medical Battalion. Chrissy has been an exemplary chief resident, a considerate and always fair in her duties as scheduling chief, and importantly to me, an exceptional friend. Please join me in welcoming Dr. Christine Tran for her grand rounds titled Match or Mismatch, Rethinking the National Resident Matching Program.
Thank you, everyone. I have no disclosures. So I chose this topic because nearly everyone in this room has gone through or will go through the match. And if you're lucky, you only have to go through it once. The match is one of the most defining systems in medical training. And I thought it would be interesting to take a deep dive into the history of the match and how it became what we know it as today. Not only is it one of the most defining systems, but also it is possibly the least questioned system in medical training. Every year, it shapes tens of thousands of careers, yet many of its challenges are accepted as inevitable rather than fixable. I wanted to take a step back and ask whether the system we rely on is actually serving the applicant, the program, and ultimately patients as well as it could. I'll start with a brief overview of how the NRMP came to be. Then I'll walk through how the match has evolved over time into the system we use today. From there, I'll focus on some of the challenges we're currently dealing with. And finally, I'll go through some potential strategies for improvement and what changes might make a meaningful difference. Before we start talking about the NRMP, we must first start with the rise of residency training, which follows two trends in the history of medicine. The first is the rise of the hospital. Before the Civil War, there were very few hospitals in the US, and thus very few places for residency training, even if people wished to pursue it. Between 1870 and 1914, the number of hospitals began to rise, particularly in larger cities. Combined with the rise in urbanization of the US, this meant that most Americans lived in close proximity to a hospital. Thus, the resident physician was born out of the need for a hospital workforce, and aptly named so because they lived in the hospital in order to provide 24/7 care. The second trend was the rise in specialization, which started with ophthalmology, which founded itself infested by charlatans. A newly minted doctor could become an ophthalmologist by completing a 2-year ophthalmology residency at one of the few pioneer hospitals in the country. Or they could more easily apprentice with an ophthalmologist until they were comfortable with their skills. Even more simply, they could buy a battery-handled ophthalmoscope and proclaim themselves as an ophthalmologist. Residency-trained ophthalmologists subsequently developed the solution to gatekeep their specialty that would change graduate medical education forever. In 1917, they established the first specialty board, the American Board of Ophthalmology, and they also established the first board exam. Specialties rapidly followed suit, as you can see here. And in order to prevent just anyone from taking the board exam, they required that a candidate complete a period of postgraduate residency training in that specialty. As the number of hospitals increased, the need for residents naturally increased as well. During this time period, the number of residents needed surpassed the number of medical graduates available. As a result, hospitals began recruiting medical students as early as second year. The AMC and AMA passed resolutions requesting that hospitals delayed offers until the fourth year. Columbia's dean also announced that they would not appoint interns at New York Presbyterian until April of fourth year, with the hope that other institutions would follow suit. To no one's surprise, other institutions did not, and Columbia's preferred applicants committed to other institutions, so Columbia reverted back to early recruitment. Then in 1945, Dr. Joseph Turner, who was the director of Mount Sinai at the time, attempted to establish a uniform time for intern appointments, and medical students would not release student information before an established date. The AMC would adopt this as what's known as the cooperative plan, and offers would remain open for 10 days. Eventually, that offer time period would decrease to the point where in 1949, a 12-hour deadline was deemed too long. Hospitals found that when offers were rejected after a short period of consideration, it was already too late, as their next preferred candidates had already accepted other offers. This led to hospitals issue what's called exploding offers, forcing students to accept immediately, or else the offer would be rescinded. In 1951, Dr. F. J. Mullen, Dean of the University of Chicago School of Medicine, was the one who proposed the establishment of a third-party clearinghouse and the use of rank order lists for students and hospitals to produce a match. This was trial run that same year. The original Mullen and Stolniker algorithm first matched all hospitals and students who ranked each other first. Then it would move on to a hospital's second group of preferred applicants if the students ranked them first, and so forth. At first glance, this algorithm gives students the advantage of their choices being considered earlier than hospitals' first choices. However, this match algorithm was presented to Harvard medical students in 1951 by the medical school dean, Dr. George Berry. Dr. W. Hardy Hendren III, then a fourth-year medical student at Harvard, who would later become a renowned pediatric surgeon, pointed out the problems with the algorithm, much to Dr. Berry's dismay and utter denial. The issue that Hendren identified was that the early match algorithm was not applicant optimal. It could produce unstable or unfair outcomes dependent on how preferences were ordered. Specifically, he recognized that the algorithm could penalize applicants for ranking programs honestly, meaning students might benefit from gaming their rank lists rather than listing true preferences. It could also lead to unstable matches where a student and program that preferred each other could end up unmatched to one another. In short, Hendren saw that the system was not strategy-proof and didn't reliably produce stable pairing. In 1951, Hendren organized a national student movement against the match system called the National Student Internship Committee, arguing it disadvantaged applicants. Within a month, they successfully pushed for changes, establishing a system that prioritizes student preferences, which remains the foundation of today's match. This became to be known as the Gale-Shapley algorithm after David Gale and Lloyd Shapley, who developed it, which matches applicants and programs based on preferences. One side proposes in rounds, and the other side tentatively accepts the best offer while rejecting others. This process continues until no better matches are possible, producing a stable match where no pair would rather be with each other than their assigned match. Alvin Roth helped redesign and modernize the match by applying the Gale-Shapley lead algorithm. He showed how to fix earlier flaws and helped implement the version used by the NRMP today. As a result of this work, Alvin Roth and Lloyd Shapley were awarded the Nobel Memorial Prize in Economic Sciences in 2012. Of note, David Gale had died in 2008, which made him ineligible to be a Nobel Prize winner, which is why he is often not talked about when it comes to the match algorithm. So understanding how the NRMP was created helps explain why it became such a powerful system. It was designed to bring order to a chaotic process, protect applicants from exploding order offers, and create a standardized timeline for residency placement. But the same centralized structure that solved many early problems also created new ones. So now we can ask a more important question: what problems do applicants, but also programs, face with the NRMP today? So problem number one is the NRMP in and of itself. Today, it operates as a private nonprofit organization that coordinates the residency match for tens of thousands of applicants each year. Although its mission is to create a fair, standardized system, it is also a financially robust organization, generating over $12 million annually, primarily from applicant registration fees and program participation costs. This raises an important tension. Despite its nonprofit status, the NRMP functions as a centralized marketplace with significant pricing power. Up until the past few years, application volume surged, and so had the NRMP's revenue. Without a clear reduction in applicant burden or system inefficiency. Now a decreasing number of applications per applicant, the NRMP has compensated for this loss in revenue by simply increasing fees for programs and institutions. And for many, this highlights a broader concern that the match, while essential, has evolved into a system where financial incentives are increasingly intertwined with its structure and growth. So solution number one, act of Congress. The U.S. legislative branch has recently become very interested in the match. Just over 1 month ago, on March the 27th, the House Judiciary Committee released an interim staff report titled Medical Mismatch: How a Residency Hiring Monopoly Harms Patients, Doctors, and the American Public. This report argues that the NRMP match raises significant antitrust concerns because it functions as a centralized system that coordinates hiring across competing hospitals. In a typical labor market, employers compete by offering different salaries, benefits, and working conditions. But under the match, hospitals agree, whether directly or indirectly, not to compete in this way by committing to the NRMP's all-in policy, which requires participating programs that wish to enter the match that they place all of their residency positions in order to participate. This limits alternative hiring pathways and reinforces the system's control over the labor market, making it even harder for applicants and programs to negotiate outside of this centralized process. This has led to uniform and historically stagnant resident salaries, as seen by your paychecks, regardless of geography, specialty, or applicant merit. Hallmarks of wage-fixing behavior that would normally raise red flags under antitrust law. In fact, a 2002 class action lawsuit by Dr. Paul Jung, a fellow at the time, versus the AMC, argued that the NRMP and affiliated organizations were colluding to restrict competition and suppress compensation. A federal court initially allowed the case to proceed, recognizing that plaintiffs have plausibly alleged a coordinated effort to fix wages and control hiring. However, before the case could be resolved, Congress intervened. In 2004, lawmakers passed the last-minute rider granting the match an antitrust exemption, shielding it from legal scrutiny and effectively ending the lawsuit. Since then, the NRMP has operated with broad immunity despite continuing to impose restrictions that in other industries would likely violate the Sherman Act, which was limiting job mobility, prohibiting outside offers, and coordinating employment terms across competitors. Critics argue that this exemption allows the system to suppress wages, reduce worker bargaining power, and restrict the overall supply of physicians, while avoiding the accountability that typically governs labor markets. As a result, there is growing debate over whether repealing this exemption would restore competition, improve resident conditions, and better align the residency market with standard antitrust principles. Solution number 2, another act of Congress. In 2005, a bill called the Restoring Rights of Medical Residents Act was introduced to the House of Representatives on April 24th, 2025. This was then introduced to the U.S. Senate not even 2 weeks ago on April 16th. This bill aims to restore competition in the medical residency system by repealing the 2004 antitrust exemption. But what is important to note is that the bill does not eliminate or restructure the match itself. It simply removes the antitrust exemption. In response to the recent bills and congressional hearings on the antitrust exemption, Dr. Samuel Dotson and Dr. Lori Curtin published an article this month in the Journal of Graduate Medical Education. The authors pushed back on critics' arguments that the NRMP's antitrust exemption suppresses competition and contributes to persistently low resident pay, suggesting that removing it wouldn't resolve the physician shortage and could actually destabilize the match. Instead, the authors point out deeper structural issues: limited residency positions, maldistribution of physicians, and inefficiencies in training, and argue that the NRMP has become more of a political scapegoat than the true source of the problem. But here's the part that doesn't exactly headline the paper. Dr. Curtin is the Chief Operating Officer of the NRMP and has spent over 20 years with the organization, which adds context to her argument and raises questions about her motives. Interesting that she doesn't list any conflicts of interest in this article. Problem number 2, the residency shortage. As you can see here, up until 1975, the number of intern positions was greater than the number of total applicants. It wasn't until 1975 where there was a decrease in internship positions due to the incorporation of them into integrated residencies. But after that year, the number of total applicants surpassed the number of total intern positions available and has maintained that trend today. Here's the data from this most recent match cycle. There were just over 41,000 intern spots available. At the same time, there were over 53,000 registered applicants, of which 48,000 submitted rank lists. So even before the match happens, there are simply more applicants than positions. Ultimately, only about 38,000 applicants ultimately matched into intern spots, which equates to about 80% of active applicants. This data further reinforces the need for additional residency training positions. However, the biggest barrier to the increase in the number of available residency training positions has been due to the Balanced Budget Act of 1997, which was signed by President Bill Clinton. The aim of this act was to reduce federal funding, which was largely done by decreasing Medicare and Medicaid funding. Congress at that time anticipated a surplus in physicians, and through this act, capped the number of Medicare-funded residency positions, even going as far as monetarily incentivizing hospitals to decrease their residency training programs. Instead of the surplus that Congress predicted in 1997, we are in a significant shortage. The AMC released a study in 2024 that looked at physician supply and demand. Projected demand continues to exceed projected supply, leading to a projected shortage of between 13,500 and 86,000 physicians by 2036, with a shortage in surgical specialists between 10,100 and 19,900. The Health Resources and Services Administration's project this shortage to be even higher in 2038, at over 140,000 physicians, which equates to a 12% deficit in the country. The shortage is especially felt in primary care and rural communities. These areas already have significantly fewer physicians per capita, and projections show the gap is worsening. Non-metro regions are expected to face some of the largest shortages in the coming years. This is driven by both low recruitment and poor retention. Fewer medical graduates choose rural practice, and many current rural physicians are nearing retirement. As a result, some rural counties have little to no primary care physician coverage at all. Ultimately, this isn't just a workforce issue, it's a geographic one. Without targeted efforts to place and keep physicians in rural areas, these shortages will continue to grow. This table highlights just how much worse physician shortages are in rural, also referred as non-metro areas, compared to urban settings. And this specifically looks at primary care. Overall, the non-metro areas are projected to only have 61% of needed primary care physicians, compared to 83% in metro areas. And this gap is even more striking when broken down by specialty. Geriatricians, only 45% adequacy. Internists, only 47%. Pediatricians, 57%. Even family medicine, which is the backbone of rural care, only reaches about 71% adequacy. So this isn't just a general shortage, it's a severe specialty-wide deficit in rural physician supply. So what is being done about the physician shortage? More acts of Congress. So one solution to addressing it is to increase the number of residency positions. Congress has attempted to do this by passing the Consolidated Appropriations Act of 2021, which marked a major shift in graduate medical education by funding 1,000 new Medicare-supported residency positions, the first significant increase in over 2 decades. These positions are being distributed gradually with up to 200 new slots added each year starting in 2023. Building on this, the Consolidated Appropriations Act of 2023 added another mere 200 residency positions. Overall, these laws together add 1,200 new positions and represent a long-awaited effort to address physician shortages, particularly in underserved communities and high-need specialties such as primary care and psychiatry. To combat the physician shortage that is expected in 2030, the Resident Physician Shortage Reduction Act of 2025 is a major bipartisan proposal that has been introduced to the House, aimed at significantly expanding the physician workforce by increasing the number of Medicare-funded residency positions. The bill would add 14,000 new residency slots over 7 years, making it one of the large proposed expansions of graduate medical education in U.S. history. These positions would be distributed gradually with priority given to hospitals in rural areas, underserved communities, and regions experiencing physician shortages. But as you can see here, the proposal has only made introduction and requires several more steps and years before becoming law. Solution number 2, act at the institution level. Residency positions can be made locally with a formal application process. And here's the application to request for program growth through UVA GME. The program director submits a request outlining the details and the type of expansion, such as a complement increase, as was done by our program, to increase from 5 to 6 categorical residents for the 2024 match. This also includes creating entirely new programs. While many training positions rely on Medicare support, programs can still move forward by identifying their own sources of sustainable funding, as seen here. This means that new residency spots do not have to depend on federal support. They can be created locally if departments and/or institutions are willing to invest. On to problem number 3, application fever. This figure demonstrates the number of applications submitted by applicants by specialty in 2023, where each box and whisker represents a different specialty. Each dot represents the number of applications submitted by an individual applicant. And you can see here that there is a massive spread across specialties. What also stands out is that many applicants are submitting far more applications than the median, with some applicants applying to hundreds of programs for one reason or another. This reflects a cycle of uncertainty because applicants are unsure about whether they will match. They apply broadly to maximize their chances. But as everyone does this, it increases competition and pressure pushing application numbers even higher. So instead of improving match outcomes, application fever can actually make the process more stressful, more expensive, and less efficient for everyone involved, both applicants and programs. So what's the solution to this? Preference signaling. This strategy has been implemented in the past 5 application cycles, which has evolved rapidly over the past few years. This began during the 2020-2021 application cycle when otolaryngology piloted the concept independently through the Otolaryngology Program Directors Organization website, which was outside of ERAS. Applicants were allowed 5 signals. In 2021, the idea expanded to internal medicine, general surgery, and dermatology, who adopted signaling through a supplemental ERAS application. By 2022, signaling became widespread and was fully integrated into the match. As of the 2024-2025 cycle, the strategy has become much more sophisticated. Instead of a small number of signals, many specialties now use a tiered program, such as gold and silver signals, to better reflect applicant interest. Overall, preference signaling has shifted from a small pilot to a central strategic component of the residency application process. This slide compares different approaches to the current preference signaling system. The types are divided into small number, 2-tiered, and large number. With a small number of signals, applicants are more strategic, and those signals tend to carry more weight, leading to higher interview rates. But they're limited, so interest gets concentrated in a few programs, and applicants may feel restricted. In the 2-tier system, signals are divided into gold and silver signals, where gold signals carry more weight than silver signals, adding more nuance, but both carry more weight than no signals at all. It helps applicants differentiate stronger preferences and spreads signals more evenly. However, not all programs interpret the tiers consistently, and some may heavily favor gold over silver. With a large number of signals, applicants can express interest more broadly, which may help reduce application volume overall. But the trade-off is that signals become less meaningful and harder for programs to interpret. The number of signals varies a lot by specialty. This is the preference signaling system for the upcoming match cycle. You can see here the distribution across a total of 28 specialties, with 13 using small number signals, which is fewer than 10, 2-tier, or large number, which is 10 or greater. Not only that, within each type of program signaling, there is significant variability, which shows that signaling is no longer one uniform tool. It has become specialty specific, with each field deciding how much weight and granularity they want applicants to have. The question then becomes, what is the effect of preference signaling on applications submitted? This figure shows a clear trend when looking at the 2023 match cycle. As preference signaling has been adopted, the average number of applications per applicant has decreased across many specialties, with the biggest drop seen in highly competitive specialties that also offer a large number of signals. This suggests that when applicants are given more signals, they apply more selectively. Overall, this data supports the idea that preference signaling helps curb application inflation. Now let's compare one specialty per type of signaling. This table looks at emergency medicine, dermatology, and orthopedic surgery between the 2023 and 2025 application years. What this data shows is a striking effect, particularly in more competitive specialties like orthopedic surgery and dermatology. In orthopedics, the median number of applications drops dramatically from 80 to 36. Dermatology shows an even steeper decline from 87 to just 32. So on the surface, signaling appears to be doing exactly what it is designed to do, reduce application inflation. But what's more interesting is what didn't change. Despite these large drops in applications, the number of interviews offered, attended, and ultimately ranked stayed largely stable across all specialties. In other words, applicants are submitting far fewer applications, but end up having roughly the same number of interviews and rank lists. The implication here is that signaling may be improving efficiency rather than limiting opportunity, allowing programs to identify genuinely interested applicants without requiring the same volume of applications to achieve the same outcomes. Orthopedics clearly shows that applications can drop dramatically. However, the same dramatic shift has not been seen in our own specialty, which also uses a large number signaling, albeit 15 instead of 30 signals. Applications have only decreased slightly. So what are all those extra applications actually accomplishing? If outcomes aren't changing, why does the pattern of broad application persist? It suggests that, unlike ortho, general surgery remains stuck in the cycle of over-applying. The data is not shown here, but plastic surgery essentially has not changed at all in the applications committed between these two match cycles, despite being a large number program with 20 signals. This suggests that general surgery, plastic surgery, and other large number specialties can learn from orthopedics in the use of signaling to better control application volume without compromising outcomes. How does signaling impact match statistics? This is a single institution study that highlights the impact that signaling has on its match. A large portion of applicants who were invited to interview had actually signaled. 74% of those who were invited. And that trend continues to the next stage, with most interviewed applicants also coming from the signal group. The signaling influencing who gets seen and selected. And even at the final stage, 67% of match applicants have signaled. So while it's not the only factor, it does appear to improve visibility and opportunity. A number of studies have shown the same trend across all specialties with regard to signaling. And overall, it seems to give applicants a meaningful advantage, particularly when it comes to securing interviews, which is often the biggest bottleneck in the process. You may be wondering which institution this data came from. Right here in our own backyard. This was my own single institution study. And this was these were the statistics for UVA from this recent match cycle. The problem number 4, interview hoarding. This figure highlights this phenomenon, and even among applicants who successfully matched, there's a huge spread in the number of interviews attended. Some applicants are attending well over 25 or even 30 interviews, which is enabled by virtual interviews since the COVID-19 pandemic, while others are interviewing with far fewer. So the question becomes, are all those interviews actually necessary? At a certain point, additional interviews don't meaningfully increase the chance of matching, and instead, they take up spots that could have gone to other applicants. This raises the question about whether there should be an interview cap. So ophthalmology is the only specialty to implement an interview cap. Studies have shown that applicants who interview and rank more than 10 ophtho programs have over a 90% likelihood of matching, recognizing the challenges of higher number of applications than available spots every year. And the San Francisco match, otherwise known as the SF match, which is the system that ophtho uses, introduced the interview cap in 2020-2021 resident match cycle. But they initially limited it to 20 interviews. This approach was particularly relevant as this was the year virtual interviews were prevalent and logistical barriers to accepting multiple invitations were greatly reduced. This was later adjusted to 18 and then 15 interviews in subsequent cycles. The goal was to address the disproportionate accumulation of interview invitations by a small subset of highly competitive applicants. Ophtho found that applicants with greater than 15 interviews had a 98.5% match rate, while the median number of interviews received by match applicants was 10. This suggests that the 15 interview cap may have been appropriately selected, limiting excessive interviewing while preserving opportunities for high-ranking candidates, and that these candidates were not adversely affected by the interview cap, and that this redistributes interview opportunities without negatively affecting the chances of candidates who possess traditionally strong profiles, suggesting that this improves the overall balance of interview allocation in the match process. Multiple studies have looked at the perspectives of applicants, clerkship directors, program directors, and student affairs deans on interview caps. Here are 2 studies that surveyed ophthalmology, urology, plastic surgery, orthopedics, and OB/GYN. The main finding was that most stakeholders view the current system as inequitable, largely due to application inflation and uneven interview distribution. Across all groups, there was a broad support for interview caps, which was seen as a way to improve fairness in the process. On the right, you see the distribution of perspectives, with a majority of surveyed people agreeing or strongly agreeing that an interview cap would decrease interview boarding. Problem number 5, inequity and bias. Up to this point, we've talked about the structure of the match and some of its broader challenges, but one of the most important questions is who this system actually works for. If the goal is to build a fair and representative physician workforce, we have to look beyond efficiency and start examining equity. So this section focuses on whether the match produces equal outcomes for all applicants, or if disparities persist within the system itself. One place where inequities can show up is in letters of recommendation, which play a major role in residency applications. Studies show consistent gender differences in how applicants are described. Letters for women tend to emphasize communal traits like teamwork and compassion, while letters for men often highlight leadership and independence. There also are structural differences. Letters for women are often shorter and more likely to include doubt-raising language, like weaker or more tentative endorsements. These differences may seem subtle, but across many applications, they can influence how candidates are perceived and ultimately ranked. It's another example of how bias can be embedded even in the evaluation tools we rely on. This study looked at applicants in the 2022 to 2023 match. Instead of just looking at overall match outcomes, the authors compared applicants who submitted ranked lists to those who ultimately matched. This is important because by the time you're ranking programs, you've already made it through application screening and interviews. So this really isolates what's happening at the final stage, how programs and applicants rank each other. What this study found is that disparities still persist even at this point. White applicants have higher match rates compared to applicants from underrepresented racial and ethnic groups, including Black, Hispanic, and Asian applicants. You can see on the graph on the right, the gray boxes are the white demographic, and then here this is split up between Hispanic and not Hispanic. Similarly, non-US citizen applicants were less likely to match. On the other hand, women were actually more likely to match than men. So what does this mean? It suggests that inequities in a match aren't just front-loaded at the application or interview stage. They continue all the way through to final ranking decisions. And that's important because the ranking phase is often thought of as more objective or algorithm-driven. But in reality, that suggests the ranking process itself may be contributing to these differences. The takeaway here is that if we want to improve equity in the match, we can't just focus on application review or interview offers. We also need to think carefully about how programs construct their rank lists. Even small shifts in ranking behavior, whether intentional or not, can meaningfully impact who ultimately matches and in turn, the diversity of the physician workforce. So solution number 1 for this, blinded interviews. This study looked at what happens when residency interviews are blinded to the applicant's full written application, including things like test scores and academic merits. The idea is that traditional interviews can be heavily influenced by prior knowledge, meaning interviewers may unconsciously favor applicants with stronger numerical metrics or more prestigious backgrounds. What the researchers found is that blinding interviewers changes how applicants were evaluated. When interviews didn't have access to the full application, they were more likely to rely on the interview itself, rather than being influenced by objective data like scores. More importantly, when interviewers were blinded to the written application, they ranked applicants similarly overall, but underrepresented minority applicants were ranked significantly higher compared to non-blinded reviewers. Importantly, this suggests that blinded interviews can reduce bias introduced by pre-existing impressions and shift the focus towards interpersonal skills, communication, and overall fit. The study ultimately supports the idea that blinding can help create a more equitable and balanced evaluation process by de-emphasizing traditional metrics and allowing applicants to be judged more on their performance during the interview itself. Solution number 2, standardized letters of recommendation. which were designed to address the subjectivity and inconsistency of traditional narrative letters of recommendation. As opposed to narrative letters, which often vary widely in tone, detail, and level of enthusiasm, these standardized letters use structured rating scales, comparative rankings, and standardized questions to evaluate applicants using the same criteria. Although there's a limited direct evidence proving they reduce bias, the standardized format is intended to minimize variability related to writing style or letter writer reputation. And these are now widely used in emergency medicine with similar formats adopted or piloted in dermatology, orthopedic surgery, OB/GYN, and internal medicine. And overall, while more research is needed, these letters represent a practical and increasingly adopted approach to make residency evaluation more consistent and equitable. In conclusion, this presentation only addresses the tip of the iceberg with regard to the problems associated with the match. The NRMP is still an essential part of the residency application process, but it's not without its own limitations. A lot of the issues we're seeing today aren't coming from just one place. They're built into the structure of the system itself, so there's no single fix, and the solutions presented here have their own benefits and limitations. Improving the match is going to require changes at multiple levels, whether that's increasing residency positions, refining preference signaling, or addressing how interviews are distributed. Ultimately, the goal is to create a system that's more efficient, more equitable, and more transparent for both applicants and programs. If we don't rethink the system, the match risks becoming exactly what it was meant to prevent, a mismatch. I'd like to thank the entire department for basically raising me and fostering me to become the surgeon that I am, particularly the attendings that are seen on this slide. I'd like to say many thanks to my friends who I wouldn't have been able to do residency with without my family who sacrificed a lot, and then my fiance.
Great talk. If you're really interested in this stuff, I think Brian Carmody, who is on Twitter a lot, but he thinks about this stuff in depth, and he has all kinds of YouTube videos. We invited him to the Virginia ACS stuff, but he's very, very thoughtful about this stuff, and it is fascinating to kind of go through all this, the history of it, but also the implications of it. Obviously, I think about this a lot, and I did recognize some of the numbers. I'm like, wow, that looks like us. And I have to admit, I don't know the right answer. I think in the end, at least for us, it seems to work, right? And I do wonder a little bit. Sometimes I joke with my fellow program directors whether we should just throw it into a hat and we all pick 6 names out of a hat, and that's the way we should do it. But I'm not sure that signaling is kind of solving the problems, right? And I think there's a couple issues that I see. It's not clear. When I talk to students and I advise students, how do they pick those signals, right? And you may find, so they're basically doing it on the websites. And so, once upon a time, I was not that concerned about websites and doximity rankings and this and that, because I said, once they come here, they're going to love us. But the reality is now they're picking signals based on things that they have really no knowledge about. And so these things have become increasingly important. Away rotations too, right? Away rotations I didn't think used to matter when I started this 7, 8, 9, 10 years ago. I think they matter now much more, which also creates significant inequities, right? Because if you can afford to do an away rotation, not everybody can even afford that. So every solution has its own problem. The other thing I see with signaling is, I would love to see this, and I don't know, is that I can think of lots of examples of people who came to us on interview day that almost canceled their interview and then ranked us #1. So I think that it'd be interesting to see what students do. Their signaling list might change after the interview, and in retrospect, say, oh, geez, I wish I'd signaled this program. I wish I didn't signal this program and this. Blah, blah, blah. So they're doing it on very, very little information. It does help. It does influence. And then I would love to see what other programs are doing. I suspect it's very, very similar. Because if I have an applicant and they're equal, at least on paper, and one signaled us and one didn't, why wouldn't I choose the person that says that they want to come here? Standardized letters I've also struggled with, because at the end of the day, really what it is this little thing at the top is this is the top 1%, this is the top 10%, and I feel like if I put top 20%, I might as well, I feel like I'm killing the application, right? So I think, I don't know how other people feel about that, but I would almost never put, you're in the top 50%, because I almost say throw the application in the trash. Plus, that's over my career, right? So if I'm a fifth year attending, I don't know if you're the top 1% of all the students I'm going to see over my career. Maybe you are. Maybe you are going to meet other people. So yes, now that I'm 62 years old, I can look back and say, okay, yeah, fine. But it's a cumulative thing. So I have not found those particularly helpful personally, but I understand the biases that the other things suggest.
Yeah. Back to the preference signaling, it definitely helps, like you said, talking to the orthopedic residents, it's functionally a cap. And so the concern, as you're mentioning, is you saw we matched 4 of 6 signaled interviews, but 2 did not. And so the concern would be it would limit the people, like you said, who wouldn't otherwise have preferences without being here. And so that's kind of the difficult part. And then going back to what you said about what's on the website, there has been a push for some studies and articles published by certain specialties to try to standardize the information in terms of being more transparent. But of course, like you said, it's just online and just the website. And at the end of the day, it will be pretty generic, regardless of how much information we put. And then in terms of the standardized letters, I do agree. I think the issue with the letters that we already kind of know about is that people are being left out because there are inequities to it. So a standardized letter would theoretically level the playing field, but then that would also take out the people who would benefit from having the narrative ones where they get praised and said that they're the top 1% and et cetera. And so there, like you said, there's not a really good way to, someone's going to be left out of the match, inevitably. The question is just how we can best decrease that. Dr. Howell.
Why not change the whole thing to a random lottery assignment? Every resident position in the country. We have a
Picking out of the hat, I was talking about. Of course, it's not going to happen, but I understand what you're saying. Because right now, the way the applicants too are happening is that the schools are recognizing this. They're actually moving towards, we don't really want to rank students. Our only goal is to make sure you're competent. That's what the schools are going to. UVA is going to go to that. I've had the dean say that to me. It is not our job to sort them out for you. It is our job to make sure that our students are competent. So we end up having just this mass of people that's hard to differentiate.
Dr. Medina.
In the study that you showed that for like dermatology, I think in otolaryngology, where their applications went down significantly, did that correlate at all with the transition from virtual to in-person interviews? Because I wonder if that could confound those results a little bit.
I'm not sure. I didn't actually look into that. But that's a good question. Dr. Guzman.
Christine, I applaud you on this wonderful talk, which is at its heart really a pediatric surgery talk. Because you started with Hardy Hendren, who's a giant in pediatric surgery, and the bookend is today is pediatric surgery culture. So my question for you though is about signaling. So I'm curious because signaling kind of came up as I stepped away from my PD role a few years back. And so my question is around whether signaling has had more of an impact on the specialties or subspecialties where there's already a significant self-selection before applying for that specialty. So dermatology, otolaryngology, orthopedic surgery, these are the most competitive of the specialties, not to detract from all of us in this room. But I think the applicant pool is a little bit different, but maybe less broad than in general surgery and general medicine. And do you think that the impact that's signaling has had on reducing number of interviews, number of applications, et cetera, is related to that?
I think that's a great question, and it's hard to tell, but I think it has had an impact. I think with orthopedics, limiting the interviews, it would essentially decrease people who wouldn't go to that program otherwise, but they take the interview because they have to. And so I think that's going to be increasing the success for everyone, but I haven't seen any studies or like talk to any programs specifically to see that in terms of their own specialty.
See, that was awesome. I learned a lot. I was surprised in the 1940s they gave them 12 hours to sign. It was like telegraph or?
Initially it was by telegraph. They had them all lined up, but there were some that were telephone. Earlier than that were telegraph.
There's a trend for like unionization of the residency. Are they playing a part or getting involved in the match as well, or do you think that's going to be something that's going to be their role in the future?
I think there is a role in the future. I hadn't seen any involvement of these unions. Unfortunately, we don't have a union because Virginia has made it very difficult for us to unionize. But we have looked into it. Usually the rate limiting factor is that if you want to unionize, you have to have, I think, at least 60 or 80% of the House Staff Council, but your name becomes public. And that's what kind of stops, is what we assume would eventually prevent everyone. But I think that if it doesn't seem like unionizing is super prevalent, at least from what I've seen, and the ones that do, I think they haven't gotten this widespread until working on big problems like this. But I do suspect that there will come a time where eventually, as more people unionize and gain more power, essentially, I think they will start influencing the match more. I mean, we saw in the 1940s, Dr. Hendren basically turned over the match by creating a revolution, and then Dr. Paul Jung had a lawsuit. Granted, it didn't work in our favor, but nonetheless, he had a lawsuit at the national level. So I do think at one point they will become more ingrained in the match system.
It's been a real pleasure. I'm sure all of us agree to work with you. Every time I get a call in the middle of the night, it's always succinct, right to the point, and this is just, you're like a role model to, for your junior age. Thank you so much.
Thank you.
And I also want to thank you for all that you've done for all your years, but in particular, you guys, you and Andy both, the scheduling chiefs, that is the task that is monumental. And not only should I thank you, but everybody in the, you managed the schedule and have done it, and you and both Andy both deserve a ton of credit for that. And it's really, it's not really work that we thank you enough for. So thank you for doing that.
Thank you.
I mean, some of them I might, like my wife, they told me that they're interested.
Yeah, just setting up the times for Friday.
All right.